Good evening, everyone. I think we must just give a minute. I see there's still a lot of people joining. If we can just give everybody time to jump onto the meeting. Good evening, everyone. I just want to welcome you all to the meeting tonight. I'm going to start with our meeting rules. Then Dr. Beretta will present the jaundiced child and approach to cholestasis. The Q&A will be run by Dr. Fran van der Schyff, and the meeting will close. Our housekeeping rules for tonight. If I may ask everyone to please put your full name and surname, your applicable council registration number, and an email address in the chat box. That is for your CPD certificates that will either be sent to you or to the HPCSA Council. All attendees will be muted during the presentation. If you have any questions, please type them in the message box, or during our Q&A session, we will manage that. Please refrain from using any patients' names during the discussions. Astellas' global policy is available on request, and please note that the meeting will be recorded. Thank you. Dr. Fran?
Good evening, everyone. I'm Francisca van der Schyff. I'm a transplant surgeon at the Wits Donald Gordon, and it is my honor and pleasure to introduce my colleague and friend from the Wits Donald Gordon Medical Center in Johannesburg. Dr. Marisa Beretta is a pediatric hepatologist, and she is in charge of our transplant hepatology service for our children. She is a leader in the field of pediatric liver disease, an active contributor to research and teaching all over the country. We look forward to a very informative and in-depth talk on this very important topic. Thanks, Marisa.
Thanks for the introduction, Fran, and thank you to everyone for joining us this evening and for giving us your time on a subject that is, as you can imagine, very close to our hearts, the jaundiced child and approach to cholestasis. As Fran had mentioned, this is our home, that's University Donald Gordon Medical Center, where we run the pediatric transplant unit. And as you can imagine, jaundice has a lot of relevance in our setting. I have no financial disclaimers, just to point out that please don't use this presentation as a replacement for your friendly pediatric hepatologist. We are very approachable, I promise. Just in terms of what we'll be covering this evening, so we're going to be going through an introduction to jaundice. Next, we'll be covering an approach to both jaundice and the cholestatic child. We'll be running through a few of the more dominant differentials and a few that everyone should have a familiarity with. And then we'll be touching briefly on a few complications of end-stage liver disease and the treatment of those complications. So just to start with, I think essential to the whole discussion is the definition of jaundice, which is impairment in bile formation and or flow that usually presents by the first year of age, most commonly in the first 3 months of life, and has an incidence of 1 in 2,500 term infant births, which is actually a significant proportion. It's classified into usually biliary or hepatocellular, which helps with kind of narrowing down the differentials and the possible causes. Importantly, any child that is presenting with a conjugated bilirubin of more than 17 micromoles per liter in a child less than 1 year is defined as jaundiced. This term has relevance because a lot of the terminology which defined conjugated as a proportion of a whole is falling away, and now this absolute number is taking center stage. There are other provisos in that it used to be in a child more than 3 weeks, and that is now evolving into a child more than 14 days of age. Breastfeeding has a role to play in that if a child is breastfeeding, we usually tolerate a more significant jaundice up to the age of 3 weeks, but beyond that time, it does require investigation. And also, if a preterm child is jaundiced, we also allow a little bit more time in terms of 21 days. But in all, taking into account all the definitions, if a child term has a conjugated bilirubin more than 17 micromoles per liter in the age range of beyond 14 to 21 days, then that child classifies as jaundiced. So neonatal jaundice is common. 50% of all newborns have hyperbilirubinemia, and a prolonged jaundice is defined as longer than 2 weeks and occurs in 15% of all infants. This requires prompt measurement of bilirubin, and elevated serum bilirubin is the definition of cholestasis. There are both surgical and medical causes. It is more frequent in preterm infants and up to a fifth of neonates receiving parenteral nutrition, but keep in mind that other cholestatic conditions can also present in an infant requiring parenteral nutrition. Several studies actually report a higher incidence of biliary atresia in preterm infants, so these patients must not be lost in assessment. Causes of neonatal and infantile cholestasis can be divided into a number of arenas: primary diseases of the hepatocytes, diseases of the cholangiocytes and bile ducts, infections, toxins, endocrine causes, extrahepatic causes. Underneath this is a subsection of acute liver failure, then in your metabolic conditions, which include disorders of lipid metabolism. But where do you start? So some important questions to ask is the infant acutely ill? So this is relevant in the setting of sepsis and systemic infection, also in the setting of acute liver failure, a metabolic crisis, or mitochondrial disorder. Is the coagulopathy persisting after the administration of vitamin K? That is relevant in that it then meets criteria for acute neonatal liver failure. Is the feces a colic? So everyone knows that a hypercolic stool is suspicious for biliary atresia. And is the gamma GT activity normal in cholestatic infants? Because this has relevance in the setting of metabolic conditions such as FIC1 and bile export pump deficiency and bile acid synthesis defects. So these all have a role play in playing to narrow down your differentials. But then what is your approach in the setting of jaundice? So we're going to run through history examination, laboratory examinations, imaging, histology, and genetics. All of these have some relevant information to contribute in your differentials. So in history, you need a detailed information on the onset of jaundice, changes in stool pigmentation and urine color. Previous or current pregnancies have relevance with miscarriages, pruritus, or liver disease experienced by the mother during her pregnancy, hemolytic diseases, cardiac anomalies, infections, or medication administered. The gestational and perinatal history has even further relevance with transient cholestasis occurring in low birth weight infants, prematurity, low APGAR scores, asphyxia, total parenteral nutrition, or organ failure. Genetic or metabolic congenital infections also result in intrauterine growth retardation, fetal hydrops, or malformations. And small for gestational age is actually a strong independent factor for neonatal cholestasis. Just in terms of red flags for inborn errors of metabolism, don't forget your family history with early onset acute metabolic decompensations, recurrent or chronic vomiting, selective food aversion, unusual odor of body fluids, or neurological signs or multi-organ involvement. Those are all relevant to the suspicion of an inborn error of metabolism. On examination, one of the most important aspects is hypocolic stools, and these actually need to be examined yourself. So some children present with hypocolic stools. The clinical picture may evolve rapidly, so it's important to actually reassess at short intervals in persistent cholestasis. So it's not good enough to just see a single stool. Children with initially colic stools with development of acolic stools between 2 to 4 months of age have been described. So just because you see a colic stool during early infancy doesn't mean that can't evolve into a hypocolic stool. And you should not exclude biliary atresia on the basis of a presence of normal stools in the early neonatal period as a result. The other thing is that hypocolic stools can actually be observed in Alagilles, alpha-1 antitrypsin, and cystic fibrosis. In terms of the rest of the general examination, dysmorphic features have a relevance. Growth and nutritional status, whether the child is growing or failing to thrive. Obviously, the presence or absence of a firm hepatomegaly. Splenomegaly has an important role in terms of differential because a massive splenomegaly should prompt investigation for either storage or hematological disorders. And then the other arenas that have a role to play in narrowing down your differential is your skin examination, your neurological examination, pulmonary and cardiac systems. The laboratory measures that are important and that I'd like to highlight are, of course, your serum bilirubin, which is obviously your definition of jaundice with presence and proportion of conjugated hyperbilirubinemia being front and center. The more than 20% of total bilirubin, if bilirubin is more than 85 millimoles per liter, is dropping away. As I said, the 17 millimoles per liter is taking center stage. So if you have an infant with a conjugated bilirubin more than 17 millimoles per liter, then that infant requires investigation. Just of note, conjugated and direct bilirubin are actually two independent measures. So direct bilirubin is actually the measure of both free and albumin bound, which does not specifically measure conjugated bilirubin, but is still accurate in identifying cholestasis. And a lot of laboratories in South Africa actually run a direct bilirubin as opposed to a conjugated bilirubin. But the relevance there is that a direct bilirubin of more than 17 is just as indicative of a child that requires investigation. The other laboratory value that has a relevance is your gamma GT, so levels more than 200 international units per liter with acolic stools are very strongly suggestive of biliary atresia, and values of more than 500 are almost exclusively found only in biliary atresia patients. Actually, on the other side of the spectrum, normal levels can actually be associated with a poor prognosis, and they can be linked to metabolic diseases, as we mentioned, such as BSEP and PFEC deficiency. Serum bile acids is a measure that's available. It's a sensitive marker of cholestasis and can be low or normal in bile acid synthesis defects. Other parameters that should be investigated are synthetic parameters, so they reflect liver function, which is your INR, PTT, glucose, lactate, and then in terms of other causes, alpha-1 antitrypsin phenotype, TSH and T4. Everyone knows that hypothyroidism can result in cholestasis, and then second-line investigation targeting disorders responsible for non-obstructive cholestasis. For infectious investigations, so your CMV requires DNA in blood or urine soon after birth. It's important to exclude syphilis, rubella, toxoplasmosis, enterovirus, which is a very important cause of neonatal hepatitis and cholestasis, and herpes simplex virus, which is one of the biggest causes of neonatal liver failure. Hepatitis A, B, and C are generally unwarranted. They're not really responsible for cholestasis or liver dysfunction in this age group. In terms of metabolic investigations, some of the basic investigations that are easy and available to conduct are plasma level of amino acids, your urine organic acids, plasma carnitine and acyl carnitine levels, in addition to your TSH and T4 as mentioned, with an early morning cortisol and IGF-1 that closes up your investigations for panhypopituitarism. If you suspect a possible lysosomal disorder, then you have more invasive and more intensive investigations with bone marrow aspirate trephine and liver tissue for storage cells, as well as fibroblast culture and serum chitotriosidase activity. One of the arenas I would like to concentrate on is imaging, because a lot of people conduct imaging, and being able to interpret the relevant findings on it are very important. So down the left-hand side, we actually have ultrasound and cholangiogram, and these two modalities actually are important and relevant in the terms of investigating cholestasis. On the right-hand side, we've got scintigraphy and ERCP and MRCP, and these have less relevance, and we'll discuss why. So an ultrasound should be a 4-hour fasting abdominal ultrasound. It's actually your first-line imaging technique. The reason why it is so popular and relevant is that it is non-invasive, it's easily available, it's safe, you do not need to sedate the infant, it helps to exclude other anatomical causes of cholestasis, and two findings, a triangular cord sign and an abnormal gallbladder are two of the most accurate findings in determining biliary atresia. Your cholangiogram is also very definitive, with lack of visualization of the bile duct being diagnostic of biliary atresia, with direct surgical cholangiography actually being the gold standard in terms of your imaging for biliary atresia. Now, the reason scintigraphy and ERCP and MRCP are not part of your standard workup is that scintigraphy actually has low specificity and positive predictive value. Although it has a 100% negative predictive value, in the context of pigmented stools, it should not be a standard investigation. And in no case should it delay referral. So no one should be waiting to conduct scintigraphy in terms of referring a patient onwards to a specialist center. MRCP is not reliable, as the normal biliary tract is not consistently visualized in children under the age of 3 months of age, but has value in diseases of the biliary tract other than biliary atresia. And ERCP, unfortunately, has limited availability, both in terms of equipment and experienced endoscopists. So unfortunately, those three modalities have very limited value in our setting. But I would like to highlight the fact that normal ultrasonography actually does not exclude BA, and there are subtypes of biliary atresia that can manifest with a visualized gallbladder. Our histology is actually the cornerstone of diagnosis of cholestasis. It gives you the correct diagnosis in 90 to 95% of cases. It also has prognostic value with the degree of fibrosis visualized, and helps to distinguish between intra and extrahepatic causes. Your intrahepatic is divided into intralobular and extralobular obstruction, with intralobular at the level of the liver cell canaliculus and the extralobular at the level of the intrahepatic biliary passage. On the right-hand side, you can actually see a number of things that you can visualize on histology. And this is information that you will receive in terms of integrity of the hepatocytes or signs of intracellular stress or giant cells. This is a pattern that is often visualized in the neonatal hepatitis, inflammatory infiltrates, signs of bile obstruction with bile plaques and bile duct proliferation. And this is most common finding in biliary atresia. You can see storage cells, which helps with your storage disorders, and then, as mentioned, patterns of fibrosis in terms of prognostication. Importantly, parenteral associated cholestasis, cystic fibrosis, and alpha-1 antitrypsin may actually be indistinguishable from biliary atresia. So oftentimes your histology will be unable to delineate between the three causes. And early changes in biliary atresia may be non-specific, and a biopsy performed too early may actually result in a false negative diagnosis. Therefore, serial biopsies may actually be indicated. And this is important to remember, because biliary atresia is actually a progressive disorder, so it changes over time. Genetics is relevant in terms of after ruling out surgical, infectious, and secondary causes. Individually uncommon diseases account for up to a quarter of infantile cholestasis. They're usually monogenic liver diseases and range from targeted gene panels to whole exome sequencing. So these are all genetic tests that can be conducted. Overall accuracy, though, is unfortunately poorly known, but targeted gene panels has been reported to yield results of up to 60% of cholestasis if you use your clinical picture to steer your approach. It's promising as a second-tier investigation to differentiate within the different causes of intrahepatic cholestasis. Unfortunately, in South Africa, genetics is not covered by the medical aids. It is an out-of-pocket expense, with targeted gene panels costing about 8,000 to 9,000 rand. So this is not something that can be readily available and readily used unless it is something that the parents can actually afford. And this is a huge impairment to using this particular investigation. Screening has an incredibly important role to play. And the two that I would like to highlight are the stool card and the neonatal blood spot card. So just to take into account the criteria for screening, so it must be in order for screening to be economically viable, it must be an important public health problem. Without identification and intervention, it should have a significant mortality and morbidity at a young age. It needs to have recognizable early symptomatic stages. There should be well-established care pathways with clearly defined diagnostic features and acceptable treatment regimes, and timely intervention must improve outcome and must be cost-effective. And if you look at those, then both biliary atresia and metabolic disease actually meet criteria for screening protocols. So screening tools that are available are a stool card for biliary atresia. This is a card that gives you the colors of stools and is interpreted by both caregivers and health professionals. It is affordable. It is applicable even in a middle-income country. It has been successfully implemented on a national basis in Taiwan, but only at a local base elsewhere. And we'll discuss reasons as to why. And the neonatal blood spot card is another screening tool that is available. So the incidence of disorders tested on neonatal blood spot cards is 1 in 2,000, which in South Africa equates to 1.4 births per day. It is extended newborn screening. In South Africa, we screen only 0.4% of population, with 25% of the private population being screened. So 3/4 of our private population are not being screened. None of our governmental population is being screened, with only 0.4% of our population actually being screened. What this equates to is that we are detecting only 2 children out of 500 disorders that have treatment available. In terms of the stool card, there are a number that are available. And while it seems like quite an easy intervention, one needs to note that the requirements for printing a stool card are actually quite stringent, because as you can imagine, the color needs to be correct in terms of interpretation. So printing of these stool cards needs to happen at a centralized and highly controlled environment so that the colors are correct. As you can see on my screen, there are multiple variations that you can see in the colors there. And that relates to the fact that the digital version of these cards is actually incorrect. So the printed version of the card is actually been made that way so that when you provide a family with the stool card, the pigmentation is correct. So although in concept this should be easy, it does require a stool card that has been validated and printed at the correct pigmentation level so that the interpretation is correct. Next Biosciences provides us with our neonatal blood spot testing, and this is just the number of diseases that are tested. The ones that are relevant to us, and we'll discuss them at a later stage, are the ones that cause jaundice. Your galactosemia is one of them. Your congenital hypothyroidism is another. Cystic fibrosis has a liver component to it that can also manifest with cholestasis. But we'll discuss later, because even though a number of these do not actually present with jaundice per se, a number of these can be rectified by applying liver transplant. Just to highlight the fact that with the current amount of screening using neonatal blood spot cards, we are missing 498 out of 500 children with a treatable disorder. And that is the relevance and the importance of a screening process. All of these diseases have an intervention available that is not being applied when we miss them in the neonatal period, and does have long-standing implications in the care of that child going forward. So our differentials. Diseases of the cholangiocytes and bile ducts are probably the one that most people are familiar with, and that is because they include biliary atresia, your choledochal malformations, and Alagille syndrome. Your biliary atresia and your congenital choledochal malformations obviously have a surgical intervention available, and that is why it is important to identify them at an early stage. Biliary atresia occurs and a prevalence of 0.55 to 1.3 per 10,000 live births, and accounts for 25 to 40% of all cholestasis within the first few months of life. And that's why we're going to concentrate on it a bit. Also, because of the fact that it does have an intervention available that can have a significant impact on the future of that child. It is a rare orphan newborn liver disease, the most frequent reason for liver transplantation in childhood, and the leading cause of liver-related death in children. It is a rapidly progressive inflammatory and fibrotic process, causing partial or complete obliteration of the extrahepatic, often intrahepatic bile ducts as well. And it's important to note that the initiation of the injury occurs before or soon after birth. So just note that it is progressive. So your status changes during the infancy. It's one of the most rapidly progressive liver diseases known to man, and without intervention, all infants will die by 3 years of age. It's broadly classified according to early or late insult resulting in duct obliteration, and it is divided into a few categories: isolated, syndromic, and cystic. Isolated is the most common and is believed to develop late in gestation. It's thought to be secondary to autoimmune and inflammatory responses to a viral insult. And that pertains to the two-hit theory of biliary atresia, which is a viral infection followed by an exaggerated immune response. The syndromic is actually thought to develop from a field defect at about 10 to 12 weeks of gestational age, and that is because it is associated with other malformations. And the cystic is also thought to occur at an earlier stage in gestation because it has successfully been identified in antenatal ultrasounds. So it is a spectrum of disease that occurs from intrauterine to just shortly after birth in the extrauterine period, and it is a progressive disorder. Just in terms of the syndromic, 20% have extrahepatic malformations, the most common of which is splenic malformations with asplenia or polysplenia. Then you get those with laterality defects, which manifest with malrotation and situs inversus. And lastly, those with cardiovascular malformations and large vessel malformations, which include dextrocardia and the inferior vena cava agenesis or anomalies such as interrupted IVC. So it's important to note that if you diagnose a child with biliary atresia, 20% of those children, 1 in 5, are going to have other defects that might also impact the management of the child. Now, one of the hindrances to biliary atresia management in our country is lack of available data. As you can see, not a lot of information is coming out of either the African continent or our own country on biliary atresia. We don't know our own incidence of biliary atresia. And if you look on PubMed and you do a guided search on both cholestatic jaundice and biliary atresia, you will find an embarrassingly low number of results. So 23 results on cholestatic jaundice and 20 results on biliary atresia. So we have very, very limited data from South Africa on both jaundice, cholestatic jaundice, and biliary atresia. And this impairs our ability to actually properly identify and tailor the management of patients to our own demographics. Challenges in biliary atresia are both in diagnosis and treatment. So one of the biggest hindrances is that jaundice in newborns is considered physiological and investigation is not pursued. A lot of patients are missed in this respect. Patients are told that it is normal, that they must go home, they must put the child in the sun. We encounter a large number of patients in whom their opportunity has been missed. Monitoring of stool color by parents and caregivers is not routine. It's also important to note that we are not very accurate. So 67% of parents get stool color wrong. 37% of healthcare providers get stool colors wrong. So it actually requires people with experience with the stool cards. It actually requires the card to be taken to the healthcare provider so that it can be interpreted correctly. And as mentioned, even then it should be done by someone experienced because we are not very accurate in terms of stool interpretation as well. And scheduled well visits miss the window of opportunity. And that relates to intervention before the age of 60 days. So if we have well visits that occur at 6 weeks, we are already well into a period of investigation and possible intervention. The Kasai Porter enterostomy is the surgical correction of choice for biliary atresia, but the success decreases with age at operation. So challenges to this are late referral to an expert team. The mean age of referral in most countries is 6 weeks. Minority undergo Kasai under 60 days of age. If it is performed within 60 days of life, 70% of patients establish bile flow. If it is performed after 90 days of life, only a quarter establish bile flow. So that's a huge difference between 60 and 90 days, and that's only 4 weeks. And recent studies have actually confirmed best results if it's conducted actually under 30 days of age. So as you can imagine, our well visits often occur at 6 weeks, and that is already 2 weeks beyond the ideal time to both investigate and intervene. So in our context, how many of these challenges are present? Well, all of them. We do miss the jaundiced child because the well visits are beyond the window of opportunity. We are not monitoring stool color. We do tell parents that jaundice is physiological and we don't pursue it. And how do we fare in terms of Kasai Porter enterostomy and intervention? Well, if you look at our data, so we do have some information coming out of Pretoria, Johannesburg, and Cape Town, and you can see that we perform Kasais at an average of anywhere between 64 to 91 days. So faring worst is Pretoria, and you can see that is also reflected in their late referrals, with almost 50% of the patients being referred to them being older than 120 days. And then Johannesburg and Cape Town sitting in the 60 to 70 range. And if you look at the rest of the world, that is not atrocious, actually. The USA average is 61 days, Europe is 57 to 68. And that reflects a problem on an international basis. And that is why this is so difficult to improve, because everyone faces these challenges. Just of interest is if you look at the age of Kasai in the patients who were transplanted, which we'll get to at a later stage in the talk, those patients actually had a Kasai performed at 80 days. So you can see the delay of a Kasai, the impact of the delay in Kasai in terms of those patients going on to transplant. So we face all the challenges that have been mentioned, and this is a huge hindrance to quality care of a child with biliary atresia. Importantly, a Kasai is only successful if bilirubin is normal, completely normal, at 6 months post-Kasai. And this is relevant because we often think of pigmented stools or resolution of observed jaundice as a successful Kasai, and it's not. You've got to have serological normalization of bilirubin in order for Kasai to be successful. And the reason that is important is because a child with an unsuccessful Kasai has a different course and needs a different approach to management than that of a child with a successful Kasai. What is the rate of successful Kasai in South Africa? Looking at Red Cross, they have 20% success rate. Joburg and Pretoria, 28 and 36%. So you're looking at a range of 19 to 36%. And how does that fare in a global scale? Well, they've got a success rate of 45 to 55%. Now, this might be a reflection of a number of things, including late referrals. We conduct Kasais sometimes beyond the age of 90 days, and we've seen that that has a very poor success rate. And it also reflects the fact that we do not have centralized units that manage these patients or perform these operations. And in Britain, that is a method that they have implemented, centralizing care, that has helped to improve the outcomes of their biliary atresia patients who have had Kasais conducted. But overall, you can see that it is difficult to have a successful Kasai in a biliary atresia patients for all of those reasons that we have mentioned. So what happens to the child with a failed Kasai? So natural history of patients who do not exhibit bile flow is actually similar to those with an unrepaired biliary atresia. So their survival is only 24 to 36 months. And those who fail to demonstrate good bile flow by 3 months should be evaluated for early transplant, ideally by 3 to 6 months of age. And that is why it is important to identify patients with a poorly functioning Kasai so that these patients can get to the correct point of care to allow them to be evaluated for transplant and have a better prognosis. The second surgical consideration is a choledochal cyst, which is a pancreaticobiliary anomaly. Diagnosis is based on imaging and confirmed by cholangio MRI, and this is why we were discussing that MRI has its place, just not in biliary atresia. Surgical correction is mandatory and timely intervention is actually imperative. And actually, optimal timing in this scenario is actually over the age of 6 months when the child is more than 5 kilograms, and that is technically based. So bigger child, better outcomes. But it is very important to exclude cystic biliary atresia as these patients have a different natural course. But there is one disease of the bile duct that is not surgical, and this is important. The reason why I've highlighted not surgical, we will discuss. It is a multi-system dominant genetic disorder characterized by bile duct porosity, extrahepatic abnormalities, and characteristic facies. Everyone has heard about the little Alvin face. It has variable expressivity, suggesting modifying factors with an incidence of 1 in 123,000. It is caused by mutations of the JAG and Notch genes. JAG1 mutations account for 70%. JAG1 is a cell surface protein that acts as a ligand for Notch transmembrane receptors in the Notch signaling pathway. It is important in liver, heart, skeleton, eye, face, and kidney development. And you are actually able to see that in terms of the clinical presentation of an Alagille syndrome, which we will go through shortly. The rest of the 30% are encountered in Notch2 mutations. Essentially, these genes regulate cell differentiation, and the abnormalities that we observe reflects in this. Complex cardiac disease is the only reliable predictor of mortality. So those with complex cardiac abnormalities have a poor prognosis, and there are no predictors of progression to terminal liver failure. So nothing in the clinical presentation of the child will be able to predict who will go on to end-stage liver disease. The hepatic manifestations are multiple and important. The child presents jaundiced often with a conjugated hyperbilirubinemia. Importantly, this may resolve. So the child with transient cholestasis may in fact be an unidentified Alagille syndrome. The problem is that they go on to develop severe and debilitating pruritus. They also may develop disfiguring xanthomata, which relates to hypercholesterolemia. They often have hepatomegaly early in the course, which evolves into a splenomegaly later. They have extreme elevations in bile acid, direct bilirubin, ALP, GGT, and cholesterol. But they have stable hepatic function over very long periods. So this is a jaundiced well child. The problem is that 20% progress to cirrhosis and liver failure. And those that can be isolated for observation, well, targeted for observation, are those with a total bilirubin more than 110, with a conjugated more than 76, and cholesterol more than 13.5 in children under the age of 5. Those are the ones that are most likely to be associated with severe liver disease and require identification and referral to a specialist unit. Cardiac and vascular presentation, so 97% have a murmur, most commonly from a pulmonary artery stenosis, so a murmur that radiates throughout the pulmonary fields. However, the whole pulmonary tree may be hypoplastic. There is an association with tetralogy of Fallot. There are other vascular abnormalities, including abnormalities of the intracranial vessels, the aorta, the renal vessels, celiac, superior mesenteric subclavian artery. Importantly, these are all arterial abnormalities. Also, they have a generalized cerebral vasculopathy over and above the major vessel abnormalities that they experience. And they also get bleeding complications. This does not link to their liver disease. So these patients are prone to bleeding. They have a coagulopathy that does not relate to the liver disease. And then they have musculoskeletal presentations. So once again, the typical facies is actually a prominent forehead, deep-set eyes, pointed chin, with a saddle or straight nose with a little bulbous tip, and people say they look like little elves. They have posterior embryotoxin of the eyes. It gives their whole appearance a triangular face. However, importantly, this is very difficult to see in an infant. So a lot of these people grow into their facial features. So it's not uncommon to not be able to identify these characteristic facial features in a child that is young. Growth failure is common. Malnutrition and delayed puberty are often present. The reason for this is unknown. So your children do not often respond to nutritional rehabilitation because they are syndromically small. The genetic etiology is suspected because, as mentioned, their actual post-transplant growth is also poor. So while other diseases present with catch-up growth, these patients are just small. Cardiac and renal disease are believed to contribute to this poor growth failure, but there has not been a direct link established as yet. They have vertebral abnormalities with butterfly vertebra. Their vertebral presentations, though, are asymptomatic with no structural significance. So they are not prone to fractures. They are not prone to any other issues relating to their vertebral abnormalities. They can have shortened ulna and shortened phalanxes. They have decreased bone mineral density, and some of that may link back to malabsorption of fat, vitamin D, and calcium, and that pertains to their treatment in that you need to target that in their supplementation. So diagnosis and treatment, the histology plays an important part in that it reflects bile duct paucity on a liver biopsy. The cardiac and vertebral abnormalities are often easy to identify. They have chronic cholestasis. Posterior embryo toxin is something that can be detected via ophthalmology, and as mentioned, they can go on to grow into the typical facies. The important thing is that if you have 3 out of 5 of these manifestations, you can diagnose Alagille on a clinical basis. There is no need to actually establish a genetic origin. The hepatic features often dominate, and the identification of bile duct paucity as opposed to bile duct proliferation can sometimes assist in differentiating from BA. But as mentioned, because these diseases evolve over time, sometimes Alagille and biliary atresia patients can be mixed up. In early infancy, bile duct proliferation may actually obscure bile duct paucity. So that is one of the reasons why it is difficult to differentiate between these 2 disease courses. Narrow extrahepatic bile ducts can result in an intraoperative cholangiogram that fails to show a patent system. And the importance of that is that some of these patients land up getting a Kasai. And unfortunately, it is inappropriate and it does increase morbidity in these patients. Treatment is to optimize nutrition, fat-soluble vitamin replacement to ameliorate symptoms, of which pruritus is the worst. Rifampicin, partial external biliary drainage, and ileal bile salt reuptake inhibitors, which we'll discuss a bit later, all have a role to play in treating the pruritus. Unfortunately, ursotan, ursodeoxycholic acid, and cholestyramine are unsuccessful. And the reason why we're highlighting this is that liver transplantation in a lot of patients in Alagille is actually secondary to poor quality of life from intractable pruritus, which should not be underestimated because it has driven Alagille patients to suicide. So quality of life is an imperative part of the treatment of these patients. The other reason they go on to require liver transplant is cirrhosis, which is one of the results of long-term liver disease. On to another cause of our infantile cholestasis. So moving away from the surgical, we're moving on to medical with infectious causes. Congenital listeria is one cause of infantile cholestasis. Usually involves the liver, even though meningitis and pneumonia dominate the clinical picture. They can have both hepatosplenomegaly and jaundice. It can be isolated from blood, cerebrospinal fluid, or liver tissue, and it's treated with penicillin. Congenital tuberculosis, this is very important in our setting, may present with hepatosplenomegaly and jaundice as well, can result in progressive liver failure. Caseating granulomas can be present on liver biopsy, but the absence does not exclude it as a potential consideration. Chickenpox, varicella, severe manifestations in premature infants with hepatic, pulmonary, and extensive skin involvement. We can treat it with acyclovir. HHV6 is rare, but can be responsible for infantile cholestasis. And here's one that we don't really consider, but should be considered: respiratory syncytial virus, which can lead to severe giant cell hepatitis and fulminant organ failure. Chronic RSV can also result in chronic liver disease requiring transplantation. Other infections of note, the ones that are actually the most relevant to liver, are CMV, herpes, and enteric viruses, with CMV being the most common congenital infection in 1 to 2% of newborns. However, the majority are asymptomatic. Clinical features include a sepsis-like syndrome in very low birth weight infants, intrauterine growth retardation, and jaundice. Investigations include urine CMV PCR. Biopsy shows giant cell transformation and bile duct paucity. And your management is often your ganciclovir or valganciclovir. However, most resolve without hepatic sequelae, but fibrosis and portal hypertension have actually been described. So CMV is an important contributor to hepatic disease. Your HSV1 and 2, echovirus, and Coxsackie and adenovirus all cause severe liver failure and multi-organ failure in the first weeks of life. They have a non-specific syndrome that present with a severe hepatitis, jaundice, and coagulopathy, usually in association with other multi-organ dysfunction. It has a high mortality, and early diagnosis and intervention is essential. Investigations include your blood PCR, your CSF as well. It has those that have this vesicles, you can assess your vesicular content. And then other arenas that you can get positive cultures from are stool, throat, and then your liver biopsy can show inclusion biopsies. Again, it has an established management, a acyclovir or cidofovir. However, overall mortality is high. Looking at primary diseases of the hepatocytes, this includes endocrine, a few extrahepatic causes, and metabolic disease. I've gone to a quick guide, one slide. So primary diseases include genetic cholestatic causes, metabolic disease, and endocrine manifestations. Your genetic cholestatic diseases include progressive familial intrahepatic cholestasis, which I will now refer to as PFIC. Your bile acid synthesis defects. Your metabolic disease includes alpha-1 antitrypsin, cystic fibrosis, and citrin deficiency. And your endocrine disorders umbrella your hypothyroidism and your hypopituitarism. So PFIC is a defect in your specialized transport proteins located in the canalicular domain of the hepatocytes. Bile salt export pump is your ABCB11, sorry, that's something, transporter, which transports bile acids. Your MDR3P glycoprotein transports phospholipids, and your FIC1 protein stabilizes the structure and functional capacity of your hepatocyte. These are all genes and proteins that result in a similar clinical presentation. There are a few other genes that have been identified, and each variant is responsible for a different clinical form. The overall incidence, when you take all of them combined, is about 1 in 25,000 to 1 in 100 million. So these classify as rare to ultra rare depending on the gene abnormality. High impact mutations lead to early manifestations in infancy, and other proteins in the enterohepatic circulation may act as disease modifiers or potential targets to novel therapies. So their clinical manifestation is wide because of the number of abnormalities, the number of areas that they affect, and the proteins that may act as modifiers that can alter their clinical presentation. So how do they present? So PFIC 1 and 2 are usually early onset jaundice and unrelenting itching in the first few months of life. So once again, this particular demographic land up often getting transplanted for quality of life. They have a fat-soluble vitamin K deficiency, and the fat-soluble vitamin deficiencies can be very refractory, which manifests in this particular case of a coagulopathy. They do have extrahepatic expression, which can result in extrahepatic manifestations of pancreatitis, diarrhea, and short stature. PFIC3 presents from infancy to adulthood with less severe pruritus and a dominant picture of portal hypertension, and an estimated 10% of all diseases present with neonatal cholestasis. In terms of your serology, they present with increased aminotransferases. Your PFIC 1 and 2 actually have a low GGT. So they are often called your low GGT cholestasis PFICs. Whilst your PFIC 3 has an elevated GGT. They have a coagulopathy secondary to the vitamin K deficiency. And the most definitive diagnosis is next generation sequencing, which unfortunately we've discussed is not routinely available. They are managed symptomatically. These do respond to ursodeoxycholic acid, which enhances biliary secretion, but unfortunately, it does not have much success in relieving pruritus. That can be improved with interruption of your enterohepatic circulation with surgical diversion, either internal or external, and ileal bile acid transport inhibitors. These are IACs, and they've recently become available. They were FDA approved in 2021. They target the main intestinal uptake protein, and they are having phenomenal success in treating these patients and may be a possible alternative to transplant for quality of life. They require nutritional support, as mentioned, the fat-soluble vitamin replacement, and ultimately, some will require liver transplantation, either because of ongoing liver disease and established fibrosis, or secondary to quality of life. Your bile acid synthesis defects are a number of disorders. 9 known defects exist. They are rare and characterized by failure to produce normal bile acid and accumulation of unusual bile and intermediary metabolites within the hepatocytes. They can progress to liver failure or chronic liver disease. If recognized early, they can have a remarkable response to oral bile salt therapy. But unfortunately, a few of them, such as Zellweger's, carry a high mortality. So they present once again with cholestasis. A lot of them present with neurological manifestation as well. They are also affected by a profound fat-soluble vitamin deficiency. Jaundice is very common. They often have failure to thrive. They can also manifest with features of advanced liver disease with ascites and coagulopathy. Interestingly, they have cataracts on ophthalmological examination, and importantly, they do not have pruritus. So the very nature of the disease means that these patients do not itch. They have normal or low serum bile acids, and that is one of the diagnostic features of this disease. They have normal or low GGT. So along with FIC1 and FIC2, a low GGT cholestasis, this is in consideration. So bile acid synthesis defects along with PFIC1 and 2 for your low GGT cholestasis. Abnormal bile acid composition in serum and urine can be assessed on mass spectrometry. Unfortunately, this is not available here. So we rely on your serum assessment of your bile acids and your GGT interpretation. Again, there is next generation sequencing that can identify specific defects. The reason it would be important to identify these patients is that there is actual replacement of primary bile acids available with cholic acid and ursodeoxycholic acid. So identifying these patients is important because you can alter their clinical course and their quality of life. Along to your metabolics, your alpha-1 antitrypsin is an autosomal recessive trait occurring in 1 in 2,500 patients. Most common inherited metabolic disorder causing liver disease in infants. It is the SERPINA1 gene mutation, which causes abnormal folding of alpha-1 antitrypsin, causing a pathological structure, retaining it in the endoplasmic reticulum. Clinically, it looks very similar to biliary atresia, and we discussed that this is one of the considerations. It may present at any age, but neonatal presentation is common, may even manifest as neonatal acute liver failure. They can have acolic stools. They have hepatomegaly, but splenomegaly is rare. Unfortunately, that doesn't help narrow down your differential, because when you're assessing an infant with jaundice and a consideration for biliary atresia, they often do not have splenomegaly either. The diagnosis is based on a reduced serum alpha-1 trypsin level, but remember that your alpha-1 antitrypsin is an acute phase reactant, so it is unreliable in interpretation. The best is actually to phenotype your patient with your PIZZ being your most disease-causing phenotype and your double M being your normal phenotype. Your MZ and any variant thereof can result in differing clinical manifestations. And then again, you can actually detect your gene mutation with SERPINA1 mutation detection. Management in these patients is optimal nutrition and following up at a specialist center to detect your deterioration in liver function and the evolution of portal hypertension. Your next most common metabolic cause is cystic fibrosis with a liver disease incidence of 27 to 35%. Cholestasis is actually only present in 5.7%, with the greatest risk factor for the development of cholestasis being meconium ileus. But that does not, it's not a prognostic indicator for the evolution or development of cystic fibrosis liver disease itself. It's got a very variable clinical course. They can present with hepatomegaly or extrahepatic bile duct obstruction. They can even present with lesions that mimic biliary atresia that results in the conducting a Kasai enterostomy to restore bile flow. So it has a number of manifestations. Diagnosis is your sweat chloride analysis, although this is incredibly difficult to conduct on infants and impossible to conduct on neonates. So again, genetic testing is one of the primary tests that will help narrow it down. Fortunately, in South Africa, your cystic fibrosis mutation genetic testing is available and it is covered by medical aids. Another accessible test is fecal elastase for pancreatic insufficiency. And then lastly, ERCP or MRCP in bile duct obstruction. But we have discussed a few of the limitations of those investigations. The only management available or relevant to cystic fibrosis liver disease is ursodeoxycholic acid in the treatment to delay progression. The last of the metabolic conditions we're going to discuss is citrin deficiency, which is a lack of citrin leading to arginosuccinate synthase dysfunction. It's important for your NADPH disposition. So essentially, it is crucial in aerobic glycolysis. Clinically, they present with a transient intrahepatic cholestasis, diffuse fatty liver on ultrasound and biopsy, and it predominates in Asian infants. Diagnosis is difficult. Liver function may be abnormal or could be normal, but the diagnosis is made on your metabolic assessment with elevated levels of citrulline, tyrosine, threonine, arginine, and methionine. Management is fat-soluble vitamin supplementation, lactose-free or MCT-rich formulas, but these patients may go on to require transplantation in adulthood. And this is one of those diseases that we will also briefly touch on that may not have a significant liver component requiring follow-up during the course of the disease itself, but in which liver transplantation may have a role to play in management. Endocrine, the most commonly occurring and the ones that we will encounter are hypo or hypothyroidism and hypopituitarism. Clinically, they also present with jaundice, failure to thrive, and hypoglycemia. Diagnosis is based on measuring your pituitary hormones. In the majority, GGT is normal and aminotransferases are only slightly elevated. So this is a child that is often well, but jaundiced with episodes of hypoglycemia. So when you're presented with a child such as that, consider your endocrine causes. These patients may actually improve spontaneously, although hormone replacement can accelerate regeneration of your liver function. Cirrhosis can develop in the absence of hormone replacement. So it is strongly advised that although they can improve spontaneously, that hormone replacement is implemented. And then touching briefly on your extrahepatic causes and your disorders of lipid metabolism, your non-parenchymal cells that can result in jaundice, or your disorders of the non-parenchymal cells that can result in jaundice, are divided into lysosomal storage disorders, and we'll touch on Niemann-Pick C and lysosomal acid lipase deficiency, and then hemophagocytic lymphohistiocytosis. Niemann-Pick C is a rare neurovisceral disorder, autosomal recessive, divided into NPC 1 and 2 mutations. It is abnormal intracellular trafficking of lipids with accumulation of cholesterol and glycophospholipids in organs and has a highly variable presentation. Clinically, it presents with hepatosplenomegaly or just splenomegaly, prolonged jaundice. It can manifest with acute liver failure. It can present as fetal hydrops in pregnancy or ascites. And if they survive the liver disease of infancy, they can progress to chronic liver disease with neurological sequelae, including hypotonia, cerebellar signs, and developmental delay. The diagnosis is based on base screening tests with the chitotriosidase as screening and oxysterol detection. In terms of their liver functions, they have slightly elevated aminotransferases, decreased LDL cholesterol and HDL cholesterol, and elevated triglycerides. They have a management available as well. So they have an established treatment, which is Meglustat, which is a competitive inhibitor of glycosylceramide synthase enzyme. So again, the reason it's important to identify these patients is because there is a therapeutic modality available that alters the course of the disease. Lysosomal acid lipase deficiency is autosomal recessive. Pathogenic variants are absent or result in absent or decreased activity of the LAL enzyme. Progressive lysosomal accumulation of cholesterol esters occur in hepatocytes, and it is a continuum from complete infant onset, which is Walman's disease, to childhood or adult onset. So wide variation again. Walman's is the infantile version and presents in the first month of life and is basically progressive, leading to death by 1 year of age. It's irreversible. Hepatosplenomegaly is present often on clinical examination. They have steatorrhea and severe malabsorption. Diagnosis can be hinted at by a high total serum cholesterol, low density lipoproteins, and elevated triglycerides. Genetic confirmation, though, is the gold standard, and you can also use LAL enzyme activity to try and make this diagnosis. It also has a treatment modality, sebelipase alpha enzyme replacement. However, liver transplant may be required in progression of liver disease to cirrhosis and liver failure. Touching on hemophagocytic lymphohistiocytosis, this is a clinical syndrome of severe hypercytokinemia due to highly stimulated but ineffective immune responses. It's an inherited predisposition with an acquired trigger. Acquired forms commonly occur with infections of the herpes family. Clinically, it may present as life-threatening severe liver failure and acute liver failure. They often have prolonged fever, hepatosplenomegaly, and a pancytopenia. Their diagnosis is based on increased ferritin, triglycerides, transaminases, bilirubin, LDH, soluble interleukin-2 receptor, which is available in South Africa, and a decreased fibrinogen. A skin rash may occur as a kind of clinical manifestation and can also be biopsied in terms of supporting the diagnosis. Hemophagocytosis can also be observed in the bone marrow, and you can do genetic testing for the familial variations of it. It's fatal without treatment, which includes steroids, intravenous immunoglobulin, cyclosporin, and etoposide. We have encountered these patients, and hemophagocytic lymphohistiocytosis is one of the most common causes of your infantile and your neonatal acute liver failure. So it is an important consideration in your jaundiced infant. And then just touching on other causes of acute liver failure, you get gestational autoimmune liver disease, tyrosinemia, and mitochondrial disorders. GALD was previously neonatal hemochromatosis. They manifest with hepatic failure, with hepatic and extrahepatic iron accumulation, although iron deposition can also be observed in a couple of other disorders, including tyrosinemia 1 and inborn errors of bile acid synthesis. It's a consequence and not a cause of the disease. It is a result of maternal alloimmune injury with transplacental passage of reactive immunoglobulin, which activates fetal complement cascade. Clinically, it is an intrauterine onset disease and may present as severe liver failure straight after birth. Diagnosis is based on a conjugated and unconjugated hyperbilirubinemia, a coagulopathy, ascites, and hyperalbuminemia. Cirrhosis is actually common. You can test for anti-human C5b9 complex. Unfortunately, this is very difficult to get in this country. Management is exchange transfusion, intravenous immunoglobulin, liver transplantation for non-responders, and high IVIC during subsequent pregnancies to prevent this from recurring. Mitochondrial disorders can manifest with acute liver failure, multi-organ disease, and ALPS. ALPS is POLG deficiency. Phenotypes and inheritance vary. Features are secondary to adenosine triphosphate deficiency and impaired fat oxidation. Essentially, you do not have the energy you require to function. Mitochondrial DNA is separate and of maternal origin. You get 12% of patients are born preterm, 30% have intrauterine growth retardation, and the onset is within weeks to months. They often have systemic manifestations with vomiting, poor feeding, hypotonia, seizures, and lethargy. Diagnosis is based on an elevated serum lactate and an increased lactate pyruvate ratio of more than 25. They often have hyperglycemia, a coagulopathy, a hyperammonemia, and a variable transaminitis. These patients, the best way to diagnose them is with genetic testing. You can also get supportive testing with free fatty acids, carnitine, acyl carnitine levels, and plasma amino acids. Essentially, the management of these patients is to correct and prevent hypoglycemic episodes and acidosis. Some respond to coenzyme Q, and the role of liver transplant in this particular subset is extremely contentious because it is a multi-system involvement. And then tyrosinemia. So the one that most commonly is counted is the hereditary type 1, the hepatorenal version, which occurs in 1 in 12,000 to 100,000 Northern European births. It has been identified in our populations as well. It is fumarate acetate hydrolase deficiency, causing accumulation of toxic substrates in the liver and kidneys, which result in cell injury and death. It is autosomal recessive in nature. It manifests with severe progressive liver disease and renal tubular dysfunction. It usually manifests early in infancy with failure to thrive in hepatomegaly and can present as either acute or chronic liver disease. They usually have a marked elevation in alpha-fetoprotein. They have episodes of hyperglycemia, marked coagulopathy. So in these patients, the coagulopathy can actually be out of keeping with the rest of the clinical picture of the patient. So if you have a patient that has a marked coagulopathy and an elevated AFP, but is otherwise not fitting that picture, tyrosinemia is a consideration. They often only have a mild transaminitis, but newborn screening involves like detection of acetone in urine or blood, and that is a definitive diagnosis of tyrosinemia. This is important once again because its management strategy is dietary and nitisinone, both of which can be implemented and alter the disease course and actually defer the need for liver transplantation. In older kids beyond infancy, there are the usual considerations which we've just gone through, but I wanted to highlight a few additional considerations. Autoimmune hepatitis is a chronic active hepatitis with non-organ specific antibodies. Without treatment, these patients progress to cirrhosis. They can present at any age. So we are starting to identify the fact that infants are an important consideration in this division as well. So previously, infants were not identified because they were not being tested, but now as we test earlier, we are identifying autoimmune hepatitis in the below 2-year age range. The incidence, however, does increase with age and it is more common in girls. It can be insidious in nature with fatigue, malaise, and recurrent fevers, or it can be the complete opposite and present as fulminant acute liver failure. Diagnosis is usually based on an elevation in ALT, AST, but there's considerable variation in the degree and it can go up and down. So you can have a patient that presents with intermittent elevations in ALT and AST with normalization in between. Low albumin and elevated INRs with an elevated serum immunoglobulin. 90% will test positive for at least one autoantibody, and liver biopsy remains the gold standard for diagnosis. Your management is your immunosuppressive agents, usually corticosteroids and azathioprine. Primary sclerosing cholangitis is another autoimmune disorder. It's progressive, targeting intra and extrahepatic bile ducts, usually associated with IBD, inflammatory bowel disease, particularly ulcerative colitis. And there is a condition called overlap syndrome, which is the presence of sclerosing cholangitis in addition to autoimmune hepatitis. Diagnosis is based on elevated GGT, ALT, and conjugated bilirubin with stricturing and dilatation on MRCP or ERCP. Management in this particular disorder is very disconcerting because there is no therapy. These patients progress to require liver transplantation. And then the last one that I would like to highlight for consideration in your infants and children is your Wilson's disease. Sorry, your children. Wilson's disease is an autosomal recessive defect of ATP7B gene, codes for a protein responsible for copper trafficking. These patients cannot excrete copper, so it accumulates in the liver, brain, kidney, and eyes, and should be considered in any school age or adolescent child. Acute Wilson's mimics viral hepatitis with nausea, fatigue, and even fulminant hepatic failure. Jaundice in chronic hepatitis evolves to portal hypertension and can result in the requirement of liver transplantation. Importantly, this particular disease presents with a low ALP. So this is important in consideration for your child who's presenting with an LFT that is deranged, but a completely normal to low ALP. They usually have elevated transaminases and a conjugated hyperbilirubinemia. Importantly, Coombs negative hemolytic anemia is one of the diagnostic requirements, well, one of the diagnostic considerations for it. The rest of the parameters, low serum chloroplasmin, elevated urine copper excretion, liver tissue copper quantification, and genetic testing are all elements that contribute towards making this diagnosis. You need to have a number of them present in order for you to make the diagnosis. Genetic testing is the only test that is absolutely definitive. It is also important because if you implement copper chelators early on in the disease course, you can interrupt its progression so that they do not require liver transplantation. Essentially, if liver transplantation is not conducted and no copper chelators are introduced, this is fatal. Just briefly touching on complications. Failure to thrive is one of the biggest, with no bile drainage resulting in significant malabsorption, protein, energy, malnutrition, growth failure, and developmental delay. A subset of patients with a successful Kasai will also suffer this, despite good bile flow. Your mid-upper arm circumference and tricep skin fold are the most reliable measurements of any lean body mass and adipose tissue. Biochemical and clinical deficiencies of fat-soluble vitamins, iron, and zinc are common and need aggressive supplementation. Metabolic bone disease and long bone fractures can occur even in the absence of a documented vitamin D deficiency. Your energy requirements of high at 125 to 140% of recommended caloric requirements. Your choice of formula is MCT rich because your MCTs are water soluble and easily absorbed by this particular patient cohort. You can increase your caloric density, use glucose polymers or medium chain triglycerides to up your available energy intake, and you should preserve your protein intake. So you should not limit your protein intake in these patients. Oral feeding is preferred, but you may need to go nasogastric. Continuous nasogastric feeds actually lead to a better energy balance, and continuous or nocturnal feeds can actually be conducted safely at home. Important to note that gastrostomy tubes are actually contraindicated because of a portal gastropathy and gastric varices. Parenteral nutrition with standard protein and lipid loads may actually be required as a bridge to liver transplant in severe cases of malnutrition. Fat-soluble vitamin requirements. Your intestinal absorption of fat-soluble vitamins is severely impaired. You need to frequently assess at a minimum of every 3 months your levels. Large doses of individual vitamins is often required, and you may actually require to parenterally replace these. Iron and zinc should also be monitored due to subclinical blood loss, and or failure to thrive or unremitting bone disease should both prompt liver transplant evaluation. Bacterial cholangitis occurs frequently in 40 to 80% of Kasai patients that will have at least one episode before the age of 2. Quarter will have multiple episodes. It's associated with decreased native liver survival, with a 3-fold risk of early failure and 2-fold risk of failure by 3 years. Liver transplant should be considered if bacterial cholangitis is recurrent, occurs with multi-resistant organisms, results in life-threatening sepsis, or severely impairs quality of life due to hospitalization. Spontaneous bacterial peritonitis is usually in the setting of a transient bacteremia, has vague symptoms such as poor feeding, fatigue, fevers, increased abdominal distension, abdominal pain, vomiting, diarrhea, most commonly caused by streptococcus or gram-negative organisms, the last being anaerobes, but not really as important as the prior two. Prophylactic antibiotics in recurrent episodes is indicated. Importantly, your pneumococcal vaccine should be administered in all chronic liver disease patients. And then portal hypertension. Important to consider that hepatic fibrosis is progressive in biliary atresia, and portal hypertension develops in the majority independent of the success of Kasai. 90% of children with biliary atresia have varices, and 30% will have at least one episode of bleeding. Presents as splenomegaly with hypersplenism, and progression from low to high risk can be very rapid, We don't routinely do surveillance endoscopy because it is difficult to eradicate. There is a risk of general anesthetic, and 50% of children with biliary atresia will actually require liver transplant by 2 years of age. Sclerotherapy and banding are our choice, our treatments of choice. Banding is the procedure that is preferred due to a low bleeding rate. And in severe cases, we do consider a Stark and Blakemore tube, but it requires expertise and has a high rate of rebleeding. Major complications can occur, including esophageal rupture. Ascites and hyponatremia are also considerations. It occurs in 1/3 of patients with portal hypertension. Diuretic therapy and exclusion of sodium is the treatment of choice. We usually go potassium-sparing agents first with spironolactone. You can add furosemide in moderate to severe and go on to IV infusions of albumin when you're struggling to control ascites. In diuretic refractory, when there is respiratory compromise, you can do large volume paracentesis. The volumes are less than 200 mils per kilogram per body weight and less than 680 mils per hour. So that's a large volume that you're allowed to take off. Larger or more rapid tapping requires albumin infusion to prevent post-paracentesis circulatory dysfunction. Just of note, I'm going to go over these. This is just for your own perusal at a later stage. This just highlights what we've discussed in terms of management of pruritus, ascites, your cholangitis prophylaxis, and your medical management of variceal bleeding, which is actually your octreotide or your terlipressin. The role of transplantation is very relevant in the context of jaundice. Your indication and timing is imperative because 17.5 additional expected life years can be offered to these patients when donated living transplant is performed at a pulse of 15 to 25. But this requires there to be one or fewer systemic complications. So this needs to be timed to be before significant malnutrition and hepatic decompensation to avoid complications and improve post-transplant outcomes. Importantly, your pulp may not actually accurately reflect the severity of the disease. We are in keeping with international standards. So 56% of our patients that are transplanted at Donald Gordon are due to cholestatic jaundice. And the majority of those are biliary atresia. And you can see that all over the world, your survival with a native liver in biliary atresia is poor, no matter where you are. A few of them actually conduct primary liver transplant. But if you offer liver transplantation, if you look at the middle, survival overall, patients with biliary atresia have good survival. Challenges are delayed referral because of progressive malnutrition. Nutritional rehabilitation is of utmost importance, and you need to have early identification of the need for liver transplant and a comprehensive workup. Importantly, we're not trying to be demeaning, but all patients should be followed up at a transplant center to allow us to intervene and detect. This is just metabolic disorders that are treatable with liver transplant. Tyrosinemia, Wilson's, and alpha-1 we've discussed, as well as PFIC and mitochondrial disorders. And the reason I wanted to highlight this is because these are all on your neonatal blood spot card. If you take all of these together, you can see that there are a number of conditions that are detectable on your neonatal blood spot card that present with jaundice. And there are a number that are treatable with transplantation. Of the ones that are available on the neonatal blood spot card, there are a number that you can identify that requires the intervention of a hepatologist. And here are our tyrosinemias, our galactosemia, our alpha-1 antitrypsin, cystic fibrosis. So there are a number of disorders that you can detect on neonatal blood spot card that you can anticipate for possible detection of jaundice, possible requirement for an intervention with a hepatologist. And importantly, there are a whole host of disorders that are available that transplant has a role to play. So take to it points out jaundice in an infant more than 14 days of age requires further investigation. Coagulopathy should be ruled out in any infant presenting with conjugated hyperbilirubinemia. Biliary atresia should be excluded in any infant presenting with jaundice and pale stools. A Kasai is only successful in conjugated bilirubin is normal by 6 months post-surgery. Neonatal blood spot screening could identify 498 infants with treatable conditions. Optimization of nutrition is a key element of treatment in cholestasis, that although rare, cholestatic disease is responsible for the majority of liver transplant in children, and all children with cholestatic liver disease should be managed by or in conjunction with a pediatric hepatologist at a transplant center. Just of note, it's Mandela Day. He had a lot of wise words to share. Our children are our future, and one of the basic responsibilities is to care for them in the best and most compassionate way possible. Thank you.
Dr. Fran?
Thank you for that, Nerissa, for that amazing talk. It's a huge amount of information, and I think we've all learned a lot. I certainly have. Just as a comment, would we be able to access your talk through the Estella's website, or how would this work? Just as a kind of a reference document.
I must be honest, Anneli, if you could perhaps answer that. I know that we are recording. I'm just not sure on which platform.
Yes, so we are recording. I will send this to you, Doc, on a WeTransfer link, and you can just forward it to people that would like to see the recording.
Okay, great. If I could start off the questions with maybe, you know, you've warned us or raised the point that a lot of our kids are referred late, and that's certainly what we see in our unit. What, in your opinion, would be the most effective way of, or the strategy that you think should be implemented nationally to pick up these kids with pathological jaundice in our setting? What do you think would be a simple thing to do at a primary care level that should ring the alarm bells that this kid needs to be referred?
So I think the stool card does have a role to play. So it has been implemented in Egypt with success to show that it can be presented, well, can be used in a low to middle income setting. But that will take quite a lot of planning and like a lot of logistics and a lot of finance to implement. I think at this point in time, what we can do is heightened awareness. So I think we need to, as pediatricians, we need to actually heighten awareness about the fact that jaundice is pathological. We need to make it that at well clinics, the jaundiced child is identified and that a test is conducted, that they do a serum bilirubin on the child, so that we are not missing those patients that are being lost because of being assessed as a physiological jaundice. And the primary care setting is such an important one. So we need to educate our sisters who are seeing these kids in the clinics that a yellow baby is a problematic baby. And like I mentioned, every child, it's 14 days old, really like looks yellow. It needs to have a serum bilirubin performed.
Great. Then if I could also just make a comment and a question at the same time. A lot of children are referred with undiagnosed biliary atresia to us, or what we call a late diagnosis of biliary atresia. What do you think is as a clinician out there who gets faced with a referral of a child that's now 4 months old, you do a sonar, you don't see a gallbladder, or you've got these acolic stools. That child, what do you think is the role of referring that child to a pediatric surgeon, or should this child come straight to a transplant?
Correct. So if you, sorry, I kind of glanced over it, sorry, because we were a bit strapped for time. I apologize for that. But if you look, you can see primary transplantation is actually gaining acceptance, especially in those that are delayed referrals. Beyond 90 days, performing a Kasai has very little merit because only a quarter of those patients are going to have any success. And no one can prognosticate as to which patients are going to be successful and which aren't. We haven't identified any factors. So unfortunately, in a missed biliary atresia beyond 90 days, the best option is to refer to a transplant center for primary transplant.
Okay, great. And then just a comment from my side. You mentioned choledochal cyst excision and repair, that it's better to wait when the child's a little bit bigger. Just to note that maybe it was not clear that it's not a question of waiting for the child to be as big as possible to get operated on. They're obviously at risk of progressive secondary biliary cirrhosis. It's not as urgent as the biliary atresia child to get
so I think that's
on.
Correct. Yeah, I think part of the issue is kind of like looking at those two patient cohorts. They're two very different cohorts, you know. So your biliary atresia, you are requiring intervention immediately, whereas your choledochal cyst, you've identified the problem, and like you mentioned, you want to try and optimize the timing. The optimal timing is like 6 months, because beyond that, you're going to encounter your problems relating to your chronic effects of the choledochal cyst. So you are correct, and you do need to intervene basically at that point. So it's just a difference in timing. I think they just want to highlight the fact that a choledochal cyst doesn't require immediate intervention. You can wait until the child is a little bit bigger, but obviously you don't want to wait until you've created a situation where you've got chronic liver disease.
Great. Then there was a question in the comments on just to reiterate the role of a HIDA scan in the diagnosis of cholestatic jaundice. When do you think that's still got a role to play?
So if you are trying to diagnose biliary atresia, a HIDA scan has very little function. So that's what they're saying. It's got 100% specificity. So in other words, if you've got excretion, you've excluded biliary atresia. But if you do not have excretion, you haven't confirmed biliary atresia. So honestly, a HIDA scan, I think in our setting, it only aggravates our difficulties with referral delays and prolonging the time to getting a Kasai. I would caution against the use of HIDA scans. You can use other modalities of imaging that are more successful.
Right, thanks for that. Are there any other questions online? If you want to unmute yourself and ask your question, you're free to do so.
I see there's a hand up.
Everybody's stunned into silence.
It was a lot of information. I apologize. I realized in retrospect that it was a rather ambitious concept of getting through the entirety of infantile cholestasis in one evening.
Yeah, it's probably a textbook worth of information, but yes. I think your talk is a brilliant reference document, even if you could have access to the slides just to check, you know, kind of where you are in the workup of this child, or which pathway to follow. But in the end, the take-home message is to ask for help if you've got a child jaundiced over 14 days. Ask someone who knows, because it's not a simple problem.
Yeah, I think that is the most important take-home message, is that you do need to, a child that is jaundiced needs to, like, immediate investigation. That is the most important thing, just to not miss that window of opportunity because it's so small.
Right. I wonder if I saw Tim's hand up. Tim, are you online?
Hi, Fran.
Hey.
Hi, Marisa.
Hey, Tim.
I absolutely want to agree with your sentiment. We see so many young patients in the public sector that have been told over and over again that the child's jaundiced, it's normal, put them in the sunlight. So I really think we need to emphasize this message of doing a conjugated bilirubin at the age of 2 months or more, 2 weeks or more. Sorry.
Got it.
Got it. Okay. Thank you.
Got it. Yeah.
2 weeks, guys. 2 weeks.
Thank you. 2 weeks or
weeks,
more.
2 weeks.
And to refer everyone who has a high conjugated bilirubin.
Yeah. I think also not to wait for like the well visit. I think that's an important one as well. You know, if a parent has said to you, my child is yellow, not to say, okay, you know, it's probably physiological jaundice, you know, we'll just reassess at the well, we'll assess at the well baby visit. That's also a missed opportunity. You know, if there is concern, be proactive about it. Do your conjugated bilirubin.
Yeah, and I think we should actually advocate for this to be in the RMCI and for nurses to know about it, because that's where it's going to be picked up.
Exactly.
Great. Any other comments?
Hi, it's Rugare. I just wanted
Hi.
to ask I just wanted to ask a question quickly about the duration of the jaundice. I was always told that, you know, you wait for 21 days for the prim newborn and 14 for the term. So does this mean that even for the prim newborn at 14 days, we must start worrying? Thank you.
So to make it simple, they've kind of abbreviated all those definitions into like something that's easier. You can wait the 3 weeks for the prem infant. So they just want to highlight the fact that there's so many terms out there and so many provisions that they're trying to kind of coalesce them into something that's easier to communicate. So it's also like a term infant that is being breastfed can wait until he's 3 weeks old, and the preterm can wait until they're 3 weeks old. And there are provisos, but essentially what is being trying to be communicated is at 2 weeks, there is concern. So if you have the luxury, like a term infant who's being breastfed or a preterm, you can go to 3 weeks, but then you must follow it up at 3 weeks. So the 14 weeks is kind of a safeguard against all the provisos that are in place and that have which kind of help patients slip through the cracks in a lot of respects. So there are a few leeways, and yes, the preterm is one of them. I think though that what is happening is they're trying to make it like a more cohesive approach.
Thank you.
I see another hand up. No
I
more.
see a hand as well. I don't know where it is.
Right. Anyone else that would like to ask someone? Graham?
Marisa, hi, it's Graham here. Thank you for an outstanding talk. Just maybe a slightly different tack in terms of neonatal intensive care and parental nutrition-associated liver disease or intestinal failure-associated liver disease. What are your thoughts in terms of, first of all, prevention, and secondly, once it's established, in terms of managing it?
Oof. So in terms of avoiding, I mean, there are your lipid-based emulsions. That's basically all you can do in terms of preventing parenteral-based your cholestasis in your parenteral nutrition. In terms of managing it, in intestinal failure, you mean, like in conjunction, you mean both a child with intestinal failure and liver failure? Is that your question?
Well, more in terms of the child that's had prolonged TPN for whatever reason as a neonate, and now has kind of a parenteral nutrition-associated liver disease, whether it's from intestinal failure or other reasons.
Okay, so I think one of the cautions is that we tend to ascribe cholestasis in your parenteral nutrition child to parenteral nutrition a little bit too quickly. So we should actually be conducting kind of investigations on them, irrespective of the fact that they are on parenteral nutrition, because they are not exempt from other causes of cholestasis. So parenteral nutrition is a diagnosis of exclusion, the cholestasis secondary to parenteral nutrition. So I think the idea behind it is just be a little bit more proactive with those patients as well. If you've got a patient who is on parenteral nutrition and they are persistently cholestatic, then consider your other causes of cholestasis, because traditionally we take them off parenteral nutrition, you observe them, you see if they get better. Some of them you can't even get off parenteral nutrition, so you don't even have that luxury. Like the whole point is that we need to consider other cholestatic causes, rather investigate them and then come up with no additional confounding factors, rather than miss the boat on the possibility of a disease that you've got an intervention available for. With intestinal failure, I know it's very difficult to avoid ongoing cholestasis and liver disease. Like some people ask, can you do a liver transplant in a patient with intestinal failure or who is dependent on parenteral nutrition? And there's actually guidelines for that. So a patient who has short gut, is parenterally dependent, they're not completely excluded from liver transplantation, because we know that it's unavoidable that the liver disease is going to progress, and it's often irreversible. So those patients will go on to require liver transplantation, but just because they are requiring parenteral nutrition doesn't mean they're exempt from it.
Perfect. Thank you so much. Yeah, no, it was great. Just one other maybe side question, and it's often the soy emulsions that are the culprits, and there are fish oil emulsions overseas like Omega-Ven and so on. Do we have access to them in South Africa or not, or is that on the horizon or not?
Not that I know of, but I think maybe we need to be more proactive in that regard as well. I mean, like I've talked a little bit about the neonatal blood spot, but it's only available in private, and if the families can afford it. And I was thinking to myself as I was putting this together, that's also something we should perhaps move for as pediatricians. We need to motivate for these things. And maybe that's something that we also need to be a little bit more proactive with, is take it to Fresenius, take it to other companies, see what the chances are that we could get this stuff in. I know one of the biggest issues is that these things come in batches often, and it's not financially viable to kind of get that much in for a limited amount of patients. So perhaps the answer is to create a network where we can see how many people would have a benefit from it, so that we can present something that's actually more viable, something that's more financially viable, so that it's more attractive to these companies to bring these options in for us.
Agreed. Thank you so much.
I think that's the last person I saw. Anybody else have a comment or a question? Nope. Well, let me just thank you again, Reese. It was an amazing talk. And thanks for what must have taken you a long time and a lot of hard work to give us this very comprehensive, in-depth talk on this issue. It was lovely listening to you and seeing your face from afar. If there are no more questions, then I'll leave it to Anneli to close.
Thank you so much, Dr. Frayne. Just a big thank you to Dr. Beretta for a very informative talk. I think everyone will agree that it was really, really a great presentation. I just want to thank everyone for joining, giving up their free time tonight to listen to the talk. And then lastly, just a reminder for everyone to enter their MP numbers and email addresses in the chat box. Thanks so much, everyone. Have a good evening.